This morning we talked about framing the thought of ethics, what it is and why it's helpful in practical terms in relation to implementation science. And this afternoon, we're going to talk about another interesting-ish issue, less topical, but more relevant to the role of publication. And similar problem actually to ethics in that we don't have really good information yet on why and how do we choose a sample size outside of traditional research. So if you were doing qualitative research, who's the qualitative? Who's qualitative? Yep, grounded theory where we know. Yep. So qualitative, what's a good sample size? Tell me, good sample size. Okay, so a theoretical sample size, but what's a good sample size for qualitative? What's a number? 20 to 30? Yes. PhD trained. Yeah, again, like theoretical saturation. What if you were doing a quantitative survey? What's a good sample size? Minimum useful. Quantitative people?
It depends on the type of methodology. For example, survey may be based upon its theoretical principle for sample size.
Yeah.
And maybe like if the predicting factor maybe use rule of thumb, or
Yeah.
it depends on if like testing the model, maybe structure equation modeling based upon the parameter.
Yeah.
And
Yeah.
yeah,
So
it depends upon.
it depends on a lot of things, and you know what those things are. In the same way that you know theoretical saturation and sampling provide guidance, because we're talking research and we're research trained. Now, if we think about implementation, it's not research, right? So now if you try to think about what's my sample, it's a harder question. It's a different question. And so this project that I want to share with you today is about trying to demystify sampling. It's a it's a tricky issue because in quality improvement, a nurse could be a sampling unit. One nurse, one unit of sampling. But so could the medical record. A medical record could be a unit of sampling. Or, you know, I could be sampling our SOPs. Do you use SOP, standard operating procedure? Yeah. So my criteria could require me in one project, same project, some nurses, some medical records, some policy documents. So I can have blended sample in quality improvement. And this morning we spoke a lot about evidence-based practice, quality improvement, implementation being essentially the same. So at a high level, they have enough in common that we can say these commonalities are true. And therefore, the way we think about, well, this morning it was ethics, and this afternoon it's sampling. The way we think about sampling can be true across all of them. And part of my interest in this field is that when I have conversations with people, it's easy to talk about sampling in quantitative or qualitative terms. We come to different conclusions. Like we talk about theoretical saturation, or we talk about finding divergent cases in qualitative work, right? So we might deliberately seek out those peripherals and try to bring them in. And we don't really always have a solid number. And then if we think about quantitative work, we might do a statistical analysis, do a power analysis, and work out what's our required minimum number at a certain power in order to optimize the capacity to detect a true effect. So we've got those things and we're comfortable talking about them. But when it comes to implementation and quality improvement, our sampling is a lot more complex because my requirement might be to do implementation of best practice in the way the admission process for mental health patients in ED. But that means I need to observe nurses. It means I need to check the medical records. It means I need to look at our policy manual and procedures and see these what are these different things? And maybe even other hospital data, automatically collected data around time. How long does different elements take? So my sample is actually more complex in implementation than it might be in qualitative research. Do we agree? Are you convinced? If you're convinced, the lecture is over. So anyway, that's sort of what grabbed my attention because I keep, again, as an editor, I read papers and people in quality improvement will say, my sample was 10 nurses. Why 10? You have a 30-bed ward. Why only 10 nurses? Or they say 10 nurses, but they also check the medical records, but the medical records were not in their sampling framework. So why are not the medical records counted as part of your sampling process? And what does that mean? It means there's a lack of transparency. There's a lack of reproducibility. And I think the bigger problem in EBP is if we don't have those things, there's no transferability. No one else can replicate that study because the sampling is completely inaccurately reported. And what we need is accuracy, not for my sake as an editor, but for other people who read this work and go, oh, you work in your OBGYN in a big hospital in Thailand and you've done this project, but I can't understand anything about your sampling. They're not going to read the rest of the paper. They're not going to try to use that evidence to improve practice locally. So if we want to improve transferability of knowledge, like we all want to disseminate, so we publish and we share, but if we want to improve the uptake and use of our knowledge, it's got to be transferable. And transferability is lost if sampling isn't well managed. I don't really have any conflicts of interest to declare here. Apparently I do. And so where we're going for the next 50 minutes together is we're going to look at a roadmap towards solutions in sample sizes and methodology for quality improvement studies. I'm going to present some background and some context, and then a scoping review. We did a rapid scoping review on sampling, and I'd like to share that with you. And then hopefully there's time to also present the findings, the methods and findings of study 2, where we looked at implementation studies and we compared published implementation studies against what we found in our scoping review. All right, so study 1, this was published early this year. Oh no, this was published last year. Oh, early view last year, published this year. Yeah, so you can see our group. This was my research team in Adelaide, Lucy Lynn Lizarondo, Vanessa Boccazanian, Alexa MacArthur, and 2 of our colleagues who are implementation scientists from the JBIC. One in Poland, that's Alexandra, and one in Germany, that was Robert. So a big acknowledgement to them. Anyway, so I hope already what you see is that to think about sampling is a useful exercise to go through because it adds value to the work that we do if we understand the rationale and the methods and how that should help predict what kind of sample size. And there's a lot of issues and challenges here that I want to acknowledge. So we'll have to plan my sampling, I have to think about what is the unit that I need to sample. Is it a nurse? Is it a patient? Is it an electronic medical record? Is it a different data point? Is it a combination of data points? Very often the case. And what's going to guide my planning around my sample size, about how many units I'm going to select to study? Do I have a budget? Often there's no money, right? No money. How big is my ward? How much time can I allocate to data collection? What's my schedule like for the next fortnight? How much time can I commit to this? What are the best options for me in terms of a total sample size? What framework exists? I know I'm not looking for theoretical saturation. This is not grounded theory or phenomenology or ethnography. So theoretical saturation is not a useful framework for me. But nor is a truly empirical framework that useful. So what works for me? How do I choose a framework that will add value to my project so that I don't waste my time or anyone else's? These are the kinds of questions that confront us when we think about sampling. I'm going to, because it's straight after lunch and everyone has had a good lunch, I'm going to test your knowledge. All right, so in terms of a scoping review, some things are true and some things are false. True or false? Effective quality improvement initiatives rely on meaningful, goal-aligned data with sampling central to ensuring that data reflects problems and changes. Is this true? Who agrees? If you're in the room and you agree with this statement, be bold and put your hand up. Read it again. Effective sampling, effective improvement initiatives rely on meaningful, goal-aligned data with sampling central to ensuring that the data reflects the problem and the change being tested. Do you agree? Everyone agrees? Superb. Agree. I agree too. So maybe we are correct. What about this? Sampling in quality improvement often prioritizes practical or pragmatic feasibility and contextual relevance over and above statistical validity, statistical representation. And this reflects the real-world iterative nature of improvement. Is good? Agree? Okay. What about the third one? This one's maybe harder. Don't know. Sampling decisions are critical to the validity and or applicability of quality improvement. But in practice, in reality, these decisions are frequently underreported, inadequately justified, or applied inconsistently. True? So we have three true statements. The first two are about quality, rigor, reliability, repeatability, and a little bit about transparency. And the third one says that although 1 and 2 are both correct statements, the third statement that we all agree on is that this does not happen very often. Like we know, but we often see it does not happen. in practice. In fact, it's frequently underreported, inadequately documented, and inconsistently applied. So we all probably would like a better process, and we would like to see other people use that process more reliably. I think that's what we're saying together. Yeah. I'm glad we're on this journey together. I love working with you. Thank you. And so there's some interesting things because clinician-led quality improvements address a lot of service level issues. They're vital to the optimization and well-run nature of any healthcare facility. But they're not just about improving an organization or the quality of care. They're vital for my professional development, for me and my colleagues to learn together through mutual processes how to navigate the system and achieve a common goal. That's an incredible skill. If you can run a quality improvement project, you should be eligible for promotion because of the high level engagement, like cross-discipline, cross-profession, uh, cultural negotiation processes, and the ability to achieve those is impressive. The ability to promote good governance, teamwork, many other features. So quality improvement usually refers to the systematic use of methods and tools that improve quality, safety, efficiency, efficiency or effectiveness of health services, and sometimes reduce costs. The government wants us to reduce costs, but in quality improvement, the goal is not to reduce costs. The goal is to improve quality. Sometimes costs may come down, but sometimes and commonly costs will go up, but quality goes up as well. And each of these things is different yet complementary in terms of the capacity to contribute to improvement. And so that's helpful. You might be familiar with some other methods as well, but I want to start to move us along. All right, here's another test. I'm sorry, there's a few extra tests in this one. All right, statement number 1 on screen. Which is the key piece of information in this sentence? Is too small. When implemented, okay, I'll cancel the test. No test. All right, you're safe. Because it's too hard to read. So let me, in fact, just skip. So here's the things that I think are helpful. QI is a powerful driver of meaningful change that benefits patients, health professionals, and organizations when implemented effectively. But if not implemented effectively, none of those benefits are real, right? So we need good implementation. Clinical audit is a really useful tool for evaluating and improving, but it's better when we compare current practice to the best available evidence. If we compare current practice Ward A to Ward B, we don't know. We only know Ward A and B. But which one's better? We don't know. They could both be terrible, right? So we need to compare the best available evidence. And so clinical audit can function as a good QI method, particularly when we bring evidence into the picture. Right. So we did a scoping review because we wanted to look at the role of sampling and how it gets done and conducted. And because you're experts, I won't spend too much time on, in fact, I won't spend any time on the background. Here's the citation details. We looked at our core aims. Our core aim was to try and fill a gap in knowledge because there's not good knowledge on identifying and describing existing sampling frameworks as it relates to EBP and QI. We followed the fundamental guidelines from the JBI Evidence Synthesis Handbook for Methodology. And we put a priori protocol together and published that on Open Science Framework. So in our scoping review, we followed Prisma, and here's our Prisma flowchart, which I literally cannot read. It's tiny. It's tiny. Wow, this is not so good. I can just do this. That's okay. So we identified over 1,500 papers related to sampling in QI. And by scanning and comparing them against our inclusion criteria, we ended up with about 8 papers included. Yeah. Yeah. And I'm going to jump to the primary result first. So when you think about sampling in research, if you're like me, you probably think about a hierarchy of methods. So what would be an example of something higher up in the hierarchy? Statistical type. Like if you had to say, where does statistical sampling fit? Would you say high or would you say low? Out of all of the approaches to sampling, like we've talked about theoretical saturation, we've talked about like minimum number for survey, or there's probabilistic sampling where we do a full power analysis. In my head, those have always been hierarchical. And I would have said probabilistic sampling is highest, objective reality. And then you sort of like work your way down to convenience and modes of convenience and purposive sampling. And I think I was wrong. So in this scoping review, we looked at all these different studies and the methods of sampling, and we came to this conclusion. So sampling is what you said before, is fit for purpose. And everyone agreed. Is okay, I will give you my slides as well. So, but this, you can see, this is not a hierarchy, right? This is not top at number 1, number 2, number 3, number 4. Instead, what we found was it's better to reframe and conceptualize sampling on a continuum, a linear continuum. So we don't prioritize one method of sampling over another. We say all useful depending on what you want to do and how you want to do it. So select, and the two ends of a continuum are still on the same level, right? So at one end, we've got non-probability, so no statistical sampling embedded. We say it's convenience, purposive, or judgment-based sampling. And this is driven by pragmatic need. If I'm doing QI in my ward and I've got 10 beds and I've got 1 month to finish data collection, out of pragmatic need, I might choose 10 sampling units. It's not a problem. I just need to say that in my paper. We have a 10-bed unit with low throughput. We had 1 month for data collection. And to ensure we got completeness of data collection, we selected a sampling size of n equals 10. That's very small, but it's explained. And the lack of explanation is actually a bigger problem than a small sample size. So sampling can be pragmatic based on what's available, what our need is. This is really useful for things where we don't have a lot of time, a lot of money, or where there's not a lot of room for complexity and management of complexity. And still on a continuum, so same level, not a hierarchy, same level, but at the other end of the continuum is representative or probabilistic sampling. This is where we might actually use number generators, power analysis, and then start to use mechanisms like randomization, clustering, which I think we were talking about earlier today, stratification, even things like implementation science method like step wedge approach is where that sits here. So we've got these. This is sort of the actual conclusion before I tell you how we got there.
Just questions.
Yeah.
For example, for the sample
that people online can do.
I have a questions about the multi-site projects. Because right now we doing for that multi-site project, and some sites would like to use the convenience sampling, but another sites want to use a randomized, something like that. So
Yeah.
do we need to run the same procedure in each site for the multi-site projects? Because like in the small scale hospital, they prefer a convenience, but for the big hospital, they prefer a randomized control trial.
Gosh, what a complicated question. I mean, to me, I would say it depends on what your intention is with the analysis. So if you are analyzing within individual sites, then one site randomizing versus another site using convenience is okay. But if your intent is to pull all of that data, what they've done by insisting on randomization is to try and add control, like remove a risk or perceived risk of bias from the process. So that's really interesting and difficult.
Yeah, but as a result, we think that because we have a small scale hospital, so we would say to others hospital, a big hospital, then can you just use the convenience sampling, because we're gonna pull data together.
Yeah.
So can I just add that information to my manuscript at the end?
I think if your analysis is going to be kind of more measures of central tendency and descriptive, you can just combine them. If you were going to try to do more comprehensive statistical analysis that requires randomization or control, then you would have to do them separately. So even in that case, though, you could combine your randomization groups and then you could separately analyze your convenience groups. But if it's central tendency and description, you can still just combine them. Yeah. Yep, because the analytic intent isn't influenced by the method. So the analytic intent was descriptive measures of central tendency, and there isn't a requirement for randomization, but nor does randomization exclude that mode of analysis. So it will work. So when we looked at, what does this tell us about the goals or the purpose of different types of sampling, we found, convenience-based sampling, purposive judgment-based sampling is more often used for iterative learning, for rapid cycle projects, and for localized decision-making. And some actually achieved statistical generalizability as well, but it wasn't the primary purpose. It was really more about being fit for purpose, rather than objective generalizability. When we looked again at the intent around identifying generalizable findings, this was typically established at the early stages of a project, and and it was informed by context. And the other thing that was the primary informant is your interest, which is what was the intended use of the data. So some sources really did emphasize the value of statistical soundness, but that's in specific use cases. It was looking at QI or practice improvements that were generally larger, probably funded. We talked about an example from the British NHS this morning about a large funded piece of work. And so when it's intending to produce scalable, credible findings, sampling tended to focus more on the probability side of things and use randomization, stratification, or systematic selection. And the goal is related to the intended use, to reduce risk of bias and enhance statistical validity. And so approaches that lead to generalizability are useful for example, for benchmarking, formal benchmarking processes, accreditation, and informing national level policy. Sometimes the goals were purely pragmatic. This was about being what we call feasible under real world constraints. And it might be that I'm the nurse unit manager, but I'm also doing a PhD and I need to try to run my ward to the best of my ability and also do my study. Feasibility, real world constraints. And the goal is here not so much about rigor, statistical rigor, probability, etc. It's about minimizing burden on clinical teams. So that's pragmatic, real world need, and tailoring my sampling method to fit organizational readiness and decision making. It was often accompanied by clinical audit or other learning driven style such as PDSA, and helpful in terms of cost effectiveness, like lower complexity, lower cost, and the sample size process was balanced against expected benefits and resource uses. So in the literature we looked at, there was generally a fit for purpose mindset. And that's why it's not hierarchical. That's why it's a continuum. Because there's no point saying that the best approach is a true randomization system if that's not relevant to the context and setting and purpose, right? So it could be the best possible technique, but if it doesn't fit, then we've made a mistake in terms of applying something that's not intended to achieve the outcomes that we need for that. A lot of different factors then come into sampling and choice of a sampling technique, including kind of, do I have a sense of the anticipated magnitude of change? So in implementation, I measure baseline compliance. It tells me where we're at right now. But in sampling, I want to know how big a change am I trying to target here? What's a reasonable number for us to pick to try to reach? So that's an important distinction. But also, what is my intervention? How am I putting it in place? And our resources and capacity. Different types of sampling, non-probability, purposive, judgment, probability, so random, stratified, and some also some emergent adaptive type strategies. And not surprisingly, across the studies that we included, the convenience or non-probabilistic methods tended to dominate quite significantly. In terms of sampling type and method, this was based on that initial decision about, is it going to be probabilistic or purposive, convenience-based? And then do I need a specific method under that as a type or typology? So probability, randomization, non-probability, purposive, judgment, convenience, and different modes of those. Makes sense, doesn't it? Yeah. Here's then what we found in terms of probability and probabilistic sampling with a good focus on, for example, reliance on a confidence interval or a sample size calculator and some structured sampling intervals that contribute to the requirement for rigor. And this is useful particularly for larger, more substantive and funded work. And in non-probability, we had purposive convenience judgment. This was much more related to the lived utility of the sampling technique. So judgment sampling was frequently used. It was the most common by far. And this is because the majority of projects are very localized. One ward, one unit, one daycare or DOSA unit, for example. And there was no real relevance to particular statistical assumptions if that's the kind of context you're working in. So it was really about feasibility, timeliness, and pragmatic fit with real world needs. In terms of type and method as well, what we saw overall and concluded from that literature was statistical methods are still important for enhancing data credibility and promoting broader applicability of that knowledge. But while that remains true in larger, more nationally framed types of opportunities and programs, QI initiatives tend to be pragmatic and flexible and pick sampling strategies related to goals, stages, and resource constraints. All right, so there's lots of different attributes then that sort of define and describe sampling, and you're an expert group of academics and senior clinicians here in this room. And so I thought might be interesting for us to do a test together and see what is our pooled collective knowledge of the language around sampling. So that's what we're going to do. Have you got your phone with you? Everyone's got a phone with them? All right. What I'd like to do is for us to come up with, oops, what are some words or characteristics of sampling that you're familiar with? So as an example, I've given you one on screen. So sample size is a characteristic of sampling, right? So scan the QR code and it should bring up a page where you can do a word cloud. Maybe. So the question is, when you think about sampling, what words come to your mind in relation to thinking about or planning a sample size? Now I need to reshare, so I hope I don't break anything. Okay, so for those of you that are online, thank you for your patience. So size is a word, number is a word, numbers is a word, participant is a word. We've got complexity, information, power, bias, inclusion criteria. Yeah, so far 6 people have put in some word. The larger the word on the slide, the more people have said that word. It's still tiny though, isn't it? But size has been said several times. Time to collect data, diversity, inclusion criteria, information power. I really like that one. Enough to be representative. Yeah. So we've got some good descriptions. Because I'm going to run out of time, we'll go back to our PowerPoint. See if we had the same things. Okay, so here's some other words. Structure. Representativeness we had, right? Frequency, sequencing. Is it 1 round, 2 or 3? Generalizability, power calculation, confidence level, precision. These are all common kinds of framing, aren't they? So features that define our sample that came from our scoping review is that where feasibility and speed are priorities, characteristics of sampling tend to be fluid and adaptive as projects evolve. And I won't ask the question, but I think it's useful to think about which of these apply. Small chart samples, like 10 to 20 records, can be used to detect performance gaps and inform subsequent rounds of sampling. So that's what they mean by fluid and adaptable. We noted that sometimes when sampling is limited, so small samples have less capacity to describe and explain what's going on. So a small sample is not a bad thing, but we have to be honest about the limits of having a small sample. If I interview 5 people, I can't produce generalizable, transferable conclusions, right? It's pilot work, and I should use the appropriate language. But in the published literature, this is true. Sampling approaches often fail to identify inadequate performance, and they don't currently help us to define inadequate performance. And this is a limitation. So small, non-representative samples are often selected out of convenience, but this can actually, if we then are too positive in the framing of our conclusions, it's a type of bias. So we should be able to be honest about the sampling method, the sampling framework, and how that should impact the way we write our results and conclusions. So just to reiterate, here's that paper. This is our model. It's linear, not hierarchical. So we don't value one method more than another. We value the method of sampling predicted on the method of implementation and the units of analysis that we prefer. I still have about 15 minutes. I'm going to talk briefly about another study where what we did was we looked at a number of papers that were published on sampling to try and decide to what extent and with what accuracy is sampling truly conducted and published in implementation-related work. So we found 35 different studies, and to be clear, these were all published by my journal. But that doesn't mean all 35 are perfect, okay? So don't be critical. There were some problems in these. Nearly half came from the US and the rest was split, across the rest of the world, China and Brazil, and then single studies from the other countries. Most were in acute tertiary referral hospitals. That's really common. And there's the domains or the fields of practice there as well. And they're traditional kinds of areas of care. Interestingly, based on what was described in the papers, 15 of these studies were one single sampling unit. So they looked at medical records only, or they looked at nursing practice only. And 20 included multiple sampling units, which was nurses plus medical records or nurses plus physicians. But it was very difficult to establish what and how many sampling units per paper. When we tried to evaluate them separately, we had 62 different groups, but in fact, the description of this and the description of the sample sizes varied really widely and it was difficult to work out how and why. It was difficult to work out the sample size because there wasn't often clarity around the unit of sampling. Where it was a single unit, it was easy. Like we have 10 beds, we sampled 10 beds. That means n equals 10. But if the paper said we have 10 beds, so we examined 10 beds and we looked at medical records, we don't know how many medical records. So it could have been 10 medical records. That makes the sample 20, not 10. Or it could have been 100 medical records. They didn't say. So we actually don't know the sample size. And if it was empirical research, you wouldn't follow that paper, would you? So we've got some work to do on. So I'm not going to. Yes, I think you should read this, and I will test you on this table at the end of the talk. No, all this does is it shows the median, the interquartile ranges, and the max for sampling. It's simply to show it was really varied, and there wasn't a lot of explanation for the variation. We had down the very bottom is mixed. Most were mixed without specifying what they meant by mixed. So there's not a lot of clarity in how people document sampling is the conclusion. And you can see the dark blue is the largest part of each bar. Dark blue means did not describe. Did not describe. So the majority of samples were actually not described in published implementation work. I think you can do much, much better in Thailand. Much, much better. So we looked at this. We found a true disconnect between sampling frameworks, real-world implementation practices, and this really suggests we need to continue to do research in this field. So if you're wondering what PhD topic to recommend to a friend, now you can recommend 2 topics, ethics from this morning or sampling from this afternoon, right? And then somebody could do this work to give meaning to the real meaning to the data. So we're going to continue to explore sampling and sampling effectiveness in QI to try and improve decision-making and lead to better reporting standards so that authors can publish better quality work. That's the real goal. So my take-home message on sampling is this. We need transparent context-sensitive strategies. We should not assume one method is better than another. It's not a hierarchy. It's a continuum. So on a continuum, we select the most context-relevant strategy. It might not be randomization. It might be small-scale rapid cycle based on convenience. But then let me say that in my paper. Let me say we sampled 10 because we only have 10 beds. And we only sampled 10 beds. Just that fact alone improves the quality of my publication because I've been clear with the world. So strategies that are adaptable, clearer, leading to good quality guidelines, this will really advance science in our field. We're not there yet, but we would like to be there. And if we can move beyond identifying the need to developing solutions together through combination of good academics and good clinical partnership, then we can develop the guidance that helps ourselves, our colleagues, and future health professionals to make really well-informed decisions on sampling in implementation. And this will mean that we can produce more sustainable work, more robust work, more feasible evidence-based healthcare practices that have wider relevance. And to me, that's actually the true goal here, is that the improvement work that nurses in particular do be more respected, more sought after, because it has a sustainable, robust basis that can be used for EBP elsewhere. There's a short story I wanted to tell you. years ago, there was a systematic review done in South Africa on home-based care for HIV. A lot of people with HIV, overburdened system. Antivirals were not widespread, right? So health burden was significant. That was a really high quality JBI systematic review conducted by our center in South Africa. But the results were really relevant in Brazil. So they were able to take and use that information. Personally, I'm waiting for the day that implementation and QI is the same, where somebody can read an implementation report from Thailand, but they work in Cleveland, Ohio, or they work in Melbourne, Australia, and they can say, I want to do medication safety improvement, and this is a really good project report. I could repeat this project. We won't get there without better thinking about ethics and better thinking about sampling, leading to better science to guide these kinds of decisions. But I feel like we're close. I feel like we're close. And within the next few years, I expect to see more people study this. So right now, nurses study nursing. What does it mean to be a nurse? How do I think about my patients in relation to X? We actually also need nurses to study QI and implementation science and look at the methodology here. We need good PhDs in implementation. Too late for you. You're already good PhD. But we need a little bit more of that to help build this body of science. So can I just ask you as a favor, when you have people talk to you about further study, the first thing we think about normally is nursing and nursing practice, right? Can you add thinking about science and implementation science and methodology? It's the fastest growing field of inquiry worldwide. And it's also one of the fastest growing fields of employment for specialist trained individuals without bias. So not you have to be an epidemiologist, not you have to be a physician, anyone who has the skills and knowledge. It's a really employable, fast growing field. And it's one of the fastest growing fields of publication worldwide. The interest is there. Let's not let nursing be slow. So we want good research. We want good sampling. And thank you for listening so well straight after lunch. Yep.
So you talk about the sampling, and then I'm thinking about the number of the sample. It's good that you talk about this issue. In Thailand, we even worse. We have I think the confusion still existed in nursing research about the implementation work, because some of them they still test the significant difference between two groups, the group who use evidence and the group who get the usual care, and then they still test the statistical significantly, and then they said, oh, and some of them even worse, the major make them to do like randomized, and then to do like control everything, and then try to test the effectiveness between two groups. So my question is that if we develop the intervention, evidence-based intervention, and when we implement it in some setting, do we need to test the effect again, or we just do the outcome evaluation and compare, like you said, maybe compare with the unit that use evidence-based practice and another one who use like usual care, or and compare only the outcome? Or do we need to test the statistical difference between two groups and control everything, and what? Do you understand the question?
Maybe. So It's a little bit driven by what am I trying to achieve? My aims in my piece of work. So I lean toward and favor pragmatism. And as a practitioner or a nurse unit manager, if I want to promote and advance implementation of best practice, probably I'm looking for small scale rapid cycle change processes with scalability. And scalability is not dependent on my sample size. It's dependent on implementation fidelity. So have I done what I said I would do the way I said I would do it? I don't need to retest in order to achieve that. I could add that complexity, but I don't think it's a requirement to add that complexity. If I had the time and the money and the resources and expertise available, I would go, wow, let's do this full reanalytic process with statistical sampling using a probability model for sure. But also, what units am I sampling? Because people go through hospital, they don't stay in hospital. So my time one data set, if I'm measuring patient outcomes, my time one data set is one group of patients. And then I do implementation and I modify structures and processes of care to align with best practice. What if that takes 3 months or 6 months or 8 months? My patients all gone, right? So it's my time one and time two will be a different sample. So it's not that it's the same and I can measure, the same effect on the same people. I could still do, nice statistical modeling approach to sampling, but I don't think there's a strong need for it.
Okay, in that case, you just measure what the outcome, clinical outcome, right? And the
So
process outcome.
yeah, if I really lean on Don Obedian for this.
Okay.
So in Don Obedian model, 3 domains, structure, process, outcome.
Outcome.
You're right, we should measure outcome more. We're actually not very good at measuring outcomes, patient outcomes in nursing.
And process outcome. So maybe my question is not, I'm sorry, is not obvious enough. So what we confuse right now is that, do we need to test the effect of the intervention more, or we use it because to develop the evidence-based practice, which means that we elicit the intervention that has been proved by the RCT primary research already. And then, for example, we draw from the systematic review and saying that, okay, do CBT is going to decreasing the depression, something like that. And then we are going to use CBT in the ward. So we don't need to test CBT again, right? So it's implementation project is that we implement that. We try to do like on the job training, try to make it like audit try and whatever it is. And then at the end, whatever, like 6 months or a year. So we are going to collect the data on the outcome and process outcome, right? Clinical outcome, that is depression in this circumstance, and the process outcome by, measure the satisfaction, the feasibility of whatever from the provider and also from the audience, from the patient. So we don't need to test it again, right?
No.
Yeah, because here sometimes some project and the students are really, it's a pain point here. And then we kind of have like the two kind of school of thought that they need to test again and have like the hypothesis testing.
Oh, okay. Yeah, no, I would agree with you fully. If we're talking about implementing best practice, it is best practice. We're not trying to modify and test that intervention. We're trying to inculcate it into practice, into culture, into behavior. So the real work is not to experiment on the intervention and its effectiveness. The real work is to persuade our team to move into a new way of thinking and a new way of doing something. Yeah, to change their practice. So
the audit criteria
mm,
compliantly.
yeah, so audit criteria is just a great way to help standardize care.
Yes, because I think the audit criteria, when we look at that one, we know that audit criteria exists from the evidence base because we already have the evidence summary for that to get the audit criteria. So when we implement that,
For example, implement the CBT on depression. What is the audit criteria here?
based on the evidence, by the way, let me give you some example of my previous project.
These circumstances. CBT on depression. Can you give the example of the audit criteria?
So
What can
when
happen?
I say something about the audit criteria, just from my understanding when I run the project about evidence implementation, the researcher have to conduct the evidence based on the whatever the CBT have done so far for the research, and then they're gonna get the current evidence base for the CBT. And after that, I talk about the audit criteria. And after that, they will summarize the audit criteria when they based on the evidence. Based on the evidence.
Like
Based on the evidence, and can you give example
Oh.
in these circumstances?
I will let Craig talk about CBT if you want, but I just want to talk about the previous project that I understand the audit criteria. Because at the beginning, we don't know much about the project about nausea and vomiting management for the chemotherapy patients undergoing the chemotherapy. And then we have experts from JBI who run the evidence summary for us. Matthew ran that one. And Matthew run the systematic review and got the recommendation from the systematic review. Once he got the recommendation from the systematic review, and then he used that recommendation to be a inclusion criteria. It's just like the audit criteria. It's like an audit criteria checklist. And we use that one to monitor the procedure when the nurse or whatever healthcare profession provide healthcare for patients with people who suffer from nausea and vomiting. That means they got the audit criteria for the nurse who provide care for client already in that hospital. So we use that audit criteria to talk about this. It's just like the criteria that achieve to the standard care. At the beginning, at baseline data, we just call it that baseline data. That means whatever they already provide, and just check if they achieve the audit criteria, because they have audit criteria, say like they have 5 audit criteria. I can't remember that right now, but when for example, like the patients have to get the risk assessment before
So it seemed to me like the audit criteria that you are talking about is equivalent to the recommendation.
yes,
It's a
correct.
recommendation in the guideline.
Yes, that's correct.
Yeah.
So we use that one. We use that one to how to say, to evaluate the process of care. For example, at the beginning, for example, we call that just from my understanding. Yeah. Yeah, and as the baseline assessment. After that, we will interview staff who work together with that project and ask them about their opinion about the healthcare that they provide. And after that, they have to change as Craig just says, they have to change the way they provide care for the clients with the audit criteria checklist. Yeah, so it depends on the research side. for the research site that we work with them in Nong Khai province, at the beginning, they just say that, no, I don't want to change the way we did. So it's quite hard to get at the beginning as baseline data. And after that, at 3-month assessment, we still use the audit criteria to check them again.
Can you give the objective example, specific example?
Probably, I mean, that would be a hard ask.
Yes.
But an audit criteria is like a quality indicator, is a little bit like a recommendation for action. So it's got to be based on an evidence-based standard and then recommend a direction or a measurement process. So the best available evidence says use CBT. The evidence might say, therefore, you need certain resources in order to effectively provide CBT. And then the criteria, which are really quality indicators, are, well, what does the evidence say are the resources we need? And then you measure, do we have these resources? And if you get yes, then you're aligned with best practice. If you get no, you've got a gap in compliance about a resource gap. And you can say, we didn't get compliance, but it's because we lack this resource. The same with process and outcome indicators. Yeah.
Thank you. Any questions?
It's hard to remember the audit criteria in project.
Yeah. We're out of time and we're out of money. So we're going to call it. But again, thank you for being with me for the afternoon. I do really appreciate it. Thank you.
Question? Yeah, if you have question, but do you have any question? If you have question, you can ask, or if not, that is going to be at the end, right? Any question by the sampling, implementation sampling? Ajahn Tai, do you have question? One question before we go, right? Before we finish.
Could you please summarize from your scoping review in terms of how the existing research, implementation research, they, I should not say estimate sample size, but how they, what should I say? How they plan to collecting data to get in terms of enough number to demonstrate about the effectiveness of the guideline implementation based upon your scoping review.
Cool. So I hope I understand the question. So I've been talking about implementation, which is analogous to EBP, analogous to QI. Everyone say QI, right? So that's different to implementation science. So in implementation science, we're actually probably testing something experimentally. And I don't, maybe I'll just say a little bit about that difference. In implementation QI EBP, I know best practice already, and I know how to implement it. So I understand what change process I want to use. In implementation science, I know what is best practice, but I don't know the best change process. So implementation science is the study of change processes to look at which one's more effective, which one's less effective. So how should I implement CBT? What if there are 5 different ways? I could use implementation science and study the how question, how to implement. I already know CBT is great, but how to put it and inculcate in practice, that's the implementation science piece. So given that this is a question about an intervention, an implementation science intervention, the answer around sampling, and you'll read this in all the leading implementation science journals, is nearly always statistical sampling techniques. Like you might even see very sophisticated power analysis to work out an overall preferred sample size because they're effectively running an experiment. It's just that the experiment is how to implement, not is this effective. So this is also a challenge for people that do implementation, because implementation, you don't necessarily, in fact, rare in implementation to use randomization, very large numbers, multi-site, complex sampling processes like cluster randomization or those sorts of things. They're rare, so it's harder to publish. Implementation science, where you are experimenting on a mode of implementation to determine how, so what's its efficacy or effectiveness, is highly desirable for publication. So it's easier to publish, but it costs more. It relies largely on national funding frameworks and larger pieces of work. So you mean my heroes are people like Jeremy Grimshaw, Sharon Strauss, Ian Graham, and a few others that have really led the world on implementation science. And they would rely on those techniques for that, because they're testing how rather than measuring have we improved. Yeah.
Based upon I'm working with my student, we still need like some number in terms of to demonstrate about the effectiveness or changing. So we found from the literature they use like a time frame to be guide how to estimate sample size. For example, before implementation maybe take like 2 months, and also the same period, the same amount of month for the during implementation as well. However, not only thinking about the time frame, but thinking about the number of the patient that will be admitted to the hospital or to the setting as well. So to me, it's not only one rule of thumb. So we need to think about the possibility, about the real world, about the specific guideline implementation as well. For another example, my student, she implement about the critical practice guideline to prevent the post-stroke pneumonia. So at that time, she need to, because the post-stroke pneumonia not oftenly happen. So the period that she collecting data may need to like a retrospective for the before implementation, like 6 months, and then need to waiting another 6 months, same period of time. So in my point, would like you to give an example, because sometimes not only one rule of thumb to estimate sample size. And also I have another one question that we just like attend defending the student proposal. And after we develop the guideline, we're gonna be testing the feasibility of the guideline. Maybe use like a 305 or apply every recommendation. And the next step for the implementation, we discussed about should we do some like not really implement, maybe like a period of time to make the unit to familiar with the guideline or not before we implement and collecting data. We not really call the pilot study, but after we test the feasibility, not all of nurses in the unit use the guideline, because only 3 to 5 patients, right? So whenever fully implementation in the unit, they need to prepare the unit to make the unit familiar, and they use like a PDSA to be start the implement to make the people in the unit familiar with that one. And after that, when they adhere, they start to still continue care based upon the guideline and collecting data. So at the time we discussed it, should we like implement immediately and collecting data, or maybe like have the gap to prepare the unit before we do fully implementation? In your perspective, what do you think about this issue?
Yeah, these are problems that are grounded in the real world, aren't they? Like these are things people grapple with a lot. If we want to know that we've improved compliance with best practice, that implies a sequence, right? So if we if we have a baseline measure and then we implement a guideline and then we remeasure, that is the sequence. That's the right sequence for measuring compliance with best practice and whether our implementation process has achieved an improvement. If we implement a guideline and later measure, are people using the guideline? Actually, you can infer baseline because at baseline, there was no guideline. If there was no guideline, no one's following the guideline. Or if they are, they're following it from some accidental source. So traditional measurement is pre-post with an implementation phase in the middle. But if there was no SOP, no guideline, no policy, you don't really need pre. You can have more time for implement and embed and then measure later. You get the same answer because you already know baseline was going to be 0. So you can either measure 0 20, 30, 40 times, or you can say it wasn't there, therefore compliance was not possible. And then you can move on to that. So that's a very legitimate way to think about problem solving there. In terms of time frame for implementation, there is no truly magic answer here, but I would say generally it's too short. Most projects, most projects get done in a hurry, and I think we don't give enough time to the implementation piece. And I have no number, there's no magic number that says this is the perfect time frame. But how do you know that it's become implemented and embedded? We don't have an answer yet for this question. But I will say consistently, people use an implementation time frame, sometimes less than 1 month. How long does it take to change behavior of a nurse? We know it takes a while, right? So 1 month is not real. But I don't know what is real. And again, that's a domain of implementation science that we need to explore more to work out what's real. And should we be doing iterative measurement and evaluation? Should we be not just measuring pre and post, but actually having a midpoint where we also measure what are our staff doing? And what do they know about this intervention? But we don't have clear answers on that. So I can't advocate a position, sorry.